So I'm going to talk about MitraClip, and unfortunately, because there's not a whole lot of experience out there, Richard and I do share some similar slides, so I apologize if you've just seen this. And this is, again, that 82-year-old woman who came to us with a TR, and at that time, I didn't know what torrential or massive was, but I just knew that it was a lot. And I learned yesterday that at Piedmont, when it's important, they say that it's a lot. And so, just as Richard showed you, we did have to get the sinus lead out of the way. But despite that, there continued to be kind of persistent, significant TR, which then we then went in with 1 and then 2 clips. As you can see here, they're both placed on the anoseptal pair of the tricuspid valve, and we got a really nice result. She's done really well, and this is off-label therapy. And so it's really interesting, and I would love to share with you the off-label experience. We're still in the process of collecting that in the United States, but we estimate somewhere between 120 and 150 cases have been done in the United States off-label. Worldwide, I learned 2 weeks ago that it's over 1,000 now. And so this, by far, is the most common transcatheter therapy for tricuspid regurgitation in the world currently. And it's simply because we're able to leverage a lot of what we know from MitraClip and apply it to the tricuspid valve as you've seen here. So here's one paper that describes the initial experience. This is George Nikonek's paper, 64 patients, 88% of whom had functional TR. About a third of them had the procedure combined with MitraClip, and 90% of them got some significant reduction with off-label use of the MitraClip for these patients. Now, I've learned a lot since being on the Triluminate committee with Becky. We started our feasibility study last fall with the first patient enrolled in August. And there's a lot that we really have learned, and so I'll just share with you a couple of nuggets here. Richard showed you some of these images earlier. If you look at this, if there's a few take-home messages, I would tell you, learn how to do TEE for TR. So if you look at the top left-hand side, and this is what Becky has really pioneered the way here, this is a short axis view showing that commissural view of the tricuspid valve, and you can see that most of that TR is close to the aortic valve, and so it looks like it's probably more anoseptal. And so if you look on the top right-hand side, what Richard has done is he's dropped a cursor and X-planed off of that area. And you leave the X-plane on with that cursor recorded, so you know that on the right side of the top right panel, you know which pair of leaflets you're looking at for grasping. And if you don't put that cursor there, you don't know which level you're looking at across the tricuspid plane. And I think, if anything, that is probably the singular most important message that I learned, so that I can know which pair of leaflets I'm looking at across that commissure of the top left. We then, so if you go in the top right down to the bottom left, we then just, after we've dropped the cursor on that pair of leaflets, we then focus on just the pair, because as you know, and I've learned, I'm not an echo doctor, but I've learned that when you go out of X-plane into just single view, that your resolution improves, so you can see in the top left, bottom left, that you see a much better view of the leaflets you're focusing on, and you can see whether or not the clip is going to be able to grasp those leaflets. And then to confirm, we look in the transgastric views, which again, Becky has really led the way here in describing how to do this. And you look in the bottom right, you look at these, and you start doing things like measuring gaps. And so there are going to be patients in whom there's a physical limit to the MitraClip system. As many of you know, the current generation is both NTR and XTR. Thank goodness for XTR, because we get an extra 3 millimeters on either side of the arms. But there's going to be a physical limit to how far these clips can reach. And in the current off-label use, we commonly describe gaps of 5, maybe 7 as approachable, but ideally less than 5. And so here's a patient here. You can look top left-hand side, clearly just a lot of TR is what I'm going to say. And then the top right, transgastric, showing that short axis with color, showing a lot of color going through the anoseptal pair. And then if you look at the middle, bottom middle, This is where Becky and Richard will measure gaps, and you can see here the gap is enormous. And because of that enormous gap, you simply cannot pull that together with TriClip therapy. And sometimes it's not just the gaps. Sometimes it's just simply you just can't see. And this is a patient with a huge limbus. And we knew that there's a lot of TR. I don't think there's any doubt about the amount of color that's coming back there. But despite multiple different views, we just couldn't get around and see the leaflets very well. And we all know that you can't treat what you can't see. And then finally, I would say that, Becky talked about this earlier in terms of clinical endpoints. I think one of the things we're going to struggle with, well, what is meaningful? So here's a patient in the top left, baseline TR, and then we put a clip on, and I can tell you that as a perfectionist, I wasn't really happy with this. I wanted to see more TR go away. But look what happened here in terms of her RE pressure. RE pressure normalized, and she became completely asymptomatic and remains asymptomatic 2 years later. And I think we have a lot to learn, and I would love to have a few more hours with Becky and Richard to talk about how we're going to quantitate these patients, because there are challenges there. So the feasibility study for Illuminate is really getting close to wrapping up. This is a CE mark study with the feasibility centers, a feasibility study being done in the United States simultaneously. It's moderate or worse, single-arm therapy. We expect this to wrap up this fall. And then Dr. David Adams and I are the national PIs for Illuminate, and that study will kick off most likely in the first quarter of this year as a pivotal study. So this is no longer feasibility. As David describes, it's the playoffs. And so we're very excited to see how that turns out. So thank you very much.